Good afternoon, everyone. On behalf of the Cuddles Online Neonatology Initiative, I thank all of you for joining today. And today we're going to discuss about one of the most advanced cardiorespiratory management therapies, which originally started with neonatology, but has now kind of percolated into all domains of intensive care. And in fact, neonatologists use it the least. Extracorporeal membrane oxygenation or ECMO. I'm Dr. Aparna from KIMS Cuddles Neonatology team, Kondapur. In the next few minutes in this presentation, we shall be discussing about some basic terminologies with regards to ECMO, the indications for ECMO, components of an ECMO circuit, cannulation and challenges associated with cannulation, important aspects of anticoagulation therapy while giving ECMO, and some aspects of troubleshooting. Coming to the introduction, ECMO, as you all know, is a prolonged but temporary extracorporeal support to a patient's heart or lung in severe irreversible cardiorespiratory failure. Sorry, not irreversible, in reversible cases of cardiorespiratory failure. Now, there are multiple terminologies when we talk about extracorporeal support. It is different from the traditional cardiopulmonary bypass that is given during open heart surgery. Now, although this is also temporary extracorporeal support, cardiopulmonary bypass is typically a very short duration transitional support, which generally is for say 4 hours or 6 hours, where the patient is on an induced circulatory arrest, and extracorporeal support is given for the circulation, the heart as well as the lungs. Whereas ECMO, as we understand, is prolonged or longer duration and temporary extracorporeal support. There are various terminologies. ECMO, as you know, is extracorporeal membrane oxygenation. When a patient who is on severe cardiopulmonary instability requires ECMO, we also refer to this as eCPR, extracorporeal cardiopulmonary resuscitation. So the patient is initiated on ECMO while receiving CPR. We also have a term called ECOR, which is extracorporeal carbon dioxide removal. So this is a technique where oxygenation is taken care by the native lungs with or without pump. This can be done off pump as well. But carbon dioxide removal is undertaken by the extracorporeal circuit. This might be necessary in some lung diseases, say interstitial lung disease. And extracorporeal interval organ support while awaiting organ transplant, and this is often done in patients who are waiting for organ transplant when while awaiting donors for organ retrieval. So this can be done both for the non-heart beating donors for maintaining perfusion to the organs, or we might be doing ECMO for a patient, let's say severely fibrosed post-COVID lungs while awaiting lung transplant for the recipient as well. So the usual terminology of prolonged ECMO is used when the duration of support required is longer than 28 days. Now, ECMO is different from cardiopulmonary bypass, which is the support given to a patient or even for newborns who undergo open heart surgery. For a short duration or for a temporary duration, the baby is taken up over on cardiopulmonary bypass support after induced circulatory arrest. So during bypass, these are pictures taken. You can see that the newborn is in unphysiological or subphysiological condition. There is induced asystole. There is hypotension. You can see that the core body temperature is also low at 28.3 degrees. So the blood is circulated through the bypass circuit where it is oxygenated, CO2 removal is done, and then it is pumped back to the body. But this is only done for a short duration of time. And hence the role for ECMO. The objectives of providing extracorporeal membrane oxygenation support is to keep the patient alive. In this case, we are talking about the newborn. Ensure adequate gas exchange and ensure adequate perfusion. Ensure normal metabolism by providing the heart and the lungs rest. And while doing all this, it is important to prevent iatrogenic damage or to cause least possible iatrogenic injury. and allowing sufficient time for recovery of the heart and the lung. So these are a couple of pictures taken from the existing literature. This was one of the first patients who underwent ECMO. She is Esperanza, who had meconium aspiration syndrome with PPHN way back in 1975. So neonatal patients played a pivotal role in the initiation of ECMO as we know it today. She survived, and as you can see, to have a normal neurological outcome as well. But compared to the 1990s, when neonatal ECMO accounted for as high as 80% of overall ECMO runs, today, this is a figure taken from 2018. This might not look very different even today at 2025. Neonatal ECMO, both pulmonary and cardiac indications, are accounting for lesser and lesser proportion of total ECMO runs. And this data is readily and freely available in the ELSO registry, which is the ECMO Life Support, Extracorporeal Life Support Organization, which maintains a registry since 1989. We can see that although earlier neonatal ECMO was accounting for a significant proportion of total ECMO runs, now that is not the case. Now, amongst newborn ECMOs, 80% happen to be primary respiratory ECMOs and 16% are primarily cardiac ECMOs. So, wherein the primary reason for performing ECMO is a respiratory cause in 80% of the ECMO runs, and 16% is secondary to a primary cardiac condition like myocarditis or severe hemodynamic instability or post-cardiac surgery. And in 4% of the cases, it is eCPR. Survival in neonatal ECMO from available data is definitely reassuring. Survival till decannulation is as high as 83%, whereas survival till discharge is around 72%. So, which is pretty encouraging for taking up more and more utilization of neonatal ECMO in valid indications. So, why is neonatal ECMO proportion declining? This is for various reasons. Important reasons being that more and more encouraging respiratory strategies or interventions have come up in neonatology, particularly the advent of optimal use of ventilation, optimal surfactant therapy, and the increasing use of non-invasive ventilation. Obviously, that is resulting in declining rates of ventilator-induced lung pathology, VAP, pneumonia, etc. All these could be reasons, and of course, the advent of pulmonary vasodilators like inhaled nitric oxide, which work excellently in the neonatal pulmonary vascular scenario. So this is another figure wherein the bars from 1990 until 2016 show an increasing number of total ECMO runs. This is because of the wider availability of centers and the wider availability of expertise for performing ECMO across the world. And the line which is showing a declining trend is representing the total percentage of neonatal ECMO cases. So again, the same thing that we discussed, that although the total number of ECMO runs has increased from 700 to roughly around 9 to 10,000 per year, or perhaps more as we talk today, the proportion of neonatal ECMO has declined from 82 to 8%. When we look at disease-specific trend in neonatal ECMO, it is quite expected that there is declining use of ECMO in conditions like meconium aspiration syndrome, respiratory distress syndrome, and sepsis. This could be simply because of better intrapartum monitoring, leading to less severe cases of meconium aspiration syndrome, earlier detection of intrapartum hypoxia, and better management or optimal management of respiratory distress syndrome. There are newer surfactant preparations available, newer techniques of surfactant administration, and better and better utilization of CPAP, and optimal utilization of advanced ventilatory techniques like high frequency oscillation with inhaled nitric oxide. Where ECMO utilization has remained fairly static include conditions like congenital diaphragmatic hernia and PPHN. This could be because of the failure of traditional conventional therapies in these conditions, particularly in diaphragmatic hernia where neonates tend to have severe, PPHN. So now we'll move on to the types of ECMO. The two major types that we should all know is VA and VV ECMO. Of course, there are hybrid types of ECMO like VAV ECMO, etc., where there can be multiple return cannulae. But let us first start with this simple classification of ECMO, VA and VV. So the figure on your left, which is labeled as VA ECMO, we'll begin with that. So here, as you can see, as you can follow the venous line represented by the blue color. So you have the drainage cannula that is drawing venous blood represented by the blue line, and that is then that passes through the pump where the purpose of the pump is of course to make blood flow through the oxygenator and back into the body. So this obviously needs certain pressure because, as you know, venous blood is at zero or at negative pressure. So obviously the drainage cannula, the venous end of the circuit, then flowing through the pump where we kind of, the blood is pumped against the rest of the circuit, the oxygenated back to the body. There is a port here generally where you have a bubble detector sometimes post the pump and where bubbles can be taken off, and this also is not required in some newer circuits. Then blood passes through the oxygenator, which is also called as a membrane lung, wherein oxygen addition and CO2 removal is performed. And you can see in the oxygenator, you have a vent for oxygen entry and a vent for the exhaust gases to flow out of the oxygenator. We also have, of course, blood flowing in from the blue line and the oxygenated blood, which is flowing out, the red color portion. And then you have also a water vent in and a water vent outside for maintaining the temperature of blood. The blood, hence oxygenated, is again sent back through the return cannula back into an artery. So here you can see the line connected now to the one of the vessels of the iliac artery in this diagram. So this represents a VA ECMO. So here, as you can see, the deoxygenated blood from the patient's vein is pumped through the circuit, passes through the oxygenator, and then the oxygenated blood is sent back into the one of the branches of the descending aorta. So this, as you can see, bypasses both the lungs as well as the heart. So we send the oxygenated blood right back into the artery. In contrast, when you look at the figure on the right, which is VV ECMO, the venous blood or deoxygenated blood again taken out by the drainage cannula passes through the pump and then through the oxygenator and back into one of the systemic veins of the body. So this could be one of the branches of the SVC or IVC. So this is VV ECMO, wherein this the return cannula is placed in a vein. So obviously, as we can see here, the heart is not bypassed. The blood still is pumped through the native heart and then perfuses the rest of the body. So VV ECMO only bypasses the lung and does not bypass the heart. So as one can imagine, VV ECMO is of use primarily in respiratory conditions where the lungs or the pulmonary parenchyma are diseased and the patient has abnormalities in gas exchange such as hypoxia or hypercapnia, which are not manageable despite maximal ventilation. It doesn't, however, bypass the native heart. So this is considered to be the equivalent of a circulation which is in series. Whereas in VA ECMO, because one bypasses both the lungs as well as the heart, this can be of use in conditions where the patient has cardiorespiratory combined conditions or primary cardiac conditions like myocarditis, severe hemodynamic instability, shock, or post-cardiac surgery. Now, having said that, in newborns, generally we end up performing VA ECMO, that too central ECMO usually would be done, or a cardiothoracic surgeon performed VA ECMO is what is usually done. So this is a table which is showing the primary differences between VA and VV ECMO. VV ECMO, as we discussed, is done primarily in respiratory disorders where the lungs are at fault and we are trying to do ECMO to provide rest to the lungs. The heart is not bypassed. So the circulation is from vein to vein. So the cannula from which blood is removed is called as drainage cannula, and the cannula with which blood is pumped back is called as a return cannula. So here both the drainage and return cannula are in the vein. In contrast, in VA ECMO, the drainage cannula is from the vein and the return cannula is into an artery, and this is performed in cardiorespiratory conditions where both heart and lung are involved. And this circulation is akin to a parallel circulation, whereas VV ECMO is akin to series, circulation series. Now, in terms of some practical concerns, of course, VV ECMO might be a little bit simpler because when we remove the cannula, skin suturing alone might be sufficient, whereas in VA ECMO, because of the arterial cannulation, this might require arterial ligation or sometimes even a vascular repair performed by a vascular surgeon when decannulation is performed. Now we'll be discussing about the settings in ECMO. One of the primary settings is the flow, that is the ECMO flow, which is usually kept at 80 to 100 ml per kg per minute in VA ECMO and slightly higher at 100 to 120 ml per kg per minute in VV ECMO. Oxygen delivery to the patient is taken care only by the native cardiac output or by the patient's own heart in VV ECMO, whereas in VA, it is taken care both by ECMO pump as well as by the patient's native cardiac output. So if you look at all the arterial waveforms, it might appear flattened in VA ECMO. It might appear non-pulsatile, but pulsatility will be preserved when patient is on VV ECMO. So coming to monitoring, how does one assess or how does one evaluate response to ECMO or how well ECMO is performing? So this in VV ECMO, which is primarily taking up the function of the lung, is as expected assessed by the respiratory parameters such as saturation, such as the requirement for the mean airway pressure on the patient's ventilator, and by other indices like the PaO2 assessed in the blood gas. So if you start VV ECMO, you expect that the patient's saturations and PaO2, oxygenation in the blood gases would begin to improve. On the other hand, in VA ECMO, which would support both the heart and the lungs, improvement is assessed by the parameters that represent perfusion, such as mean arterial pressure, the blood pressures, the patient's lactates in the blood gases, and mixed venous saturation. So mixed venous saturation again gives us an important assessment of the patient's cardiac output and the perfusion. To some extent, pulse pressure also helps, and the return of pulsatility or the return of normal pulse pressures might indicate that more and more native cardiac function is returning back, and hence is also a parameter to show that the patient is improving on VA ECMO. Now, there are multiple hybrid subtypes, as we discussed earlier. For example, instead of one venous drainage cannula, you may choose to have two venous drainage cannula for better removal of blood from the patient. And likewise, instead of sending back the oxygenated blood from the circuit only into the vein or only in the artery, one may choose to have both a vein and an artery. So these are various subtypes, but the basic principles of VV and VA remain. Now, complications of ECMO also depend to some extent on the type. Now, for example, in VV ECMO, one of the pertinent complications or challenges is recirculation, wherein the blood that is coming back from the return line can be drawn back into the drainage cannula if the distance between the two cannulae is very short. So this is sometimes noticed by the blood in both the cannulae appearing bright red. Usually we expect the blood in the drainage line to appear dark and the return line to appear red. But if you see red blood or bright blood appearing in both these cannula, we suspect recirculation. More than 20% recirculation is taken as pathological. So this is not generally a problem with VA ECMO for obvious reasons. Whereas with VA ECMO, we may find other problems because the return blood at a significant flow of around 100 ml per kg per minute is pumped back into one of the vessels of from the descending artery. One may sometimes find LV stunning, especially in a patient with reduced myocardial function. LV stunning can be a problem, and this can be picked up by drop in saturations, blood pressure, and a state of cardiovascular collapse, and there can be increased left ventricular diastolic and diastolic pressures. This can be one of the prominent problems with the VA ECMO. In addition to this, because of the arterial cannulation per se, there can be multiple other issues, including the need for arterial ligation, the need for repair, the need for sometimes limb ischemia that may necessitate removal or reinsertion of the cannula, etc. Now, in VA ECMO, the primary advantage is, although it is technically slightly more challenging, it supports both the heart and the lungs and gives rest to both these organs, and there is no recirculation noted with VA ECMO. VV ECMO avoids the complications associated with cannulation of a major artery and neuroembolic complications. However, it only supports the baby's lungs, and no circulatory support is offered. And the blood flow rate needed in VV ECMO is generally higher, as we already discussed. It should be around 100 to 120 ml per kg per minute with VV ECMO, and is around 20% higher than the blood flow rate required for VA ECMO. The other advantages of VV ECMO are that it maintains pulmonary blood flow and provides oxygenated blood to the pulmonary bed as well, and it also maintains coronary perfusion. The pulse volume, CVP, etc., are unaffected in VV ECMO, whereas all these might get affected in VA. So, having had a basic understanding about VV and VA ECMO and their relative advantages and disadvantages, and the basic premise under which they are used, let us now discuss a little bit about indications of neonatal ECMO in particular. So, as we all know, neonatal ECMO is one of the highest end cardiorespiratory support therapies that are offered, and hence this is only reserved for neonates with severe respiratory or severe cardiorespiratory failure with high likelihood of mortality, but with a potentially reversible pathology like meconium aspiration syndrome, like sepsis, or in diaphragmatic hernia awaiting surgery or immediate post-op where there is PPHN. Notably, this should not be offered for conditions where the child has irreversible brain injury or severe brain damage. For example, in meconium aspiration syndrome, if the baby also has hypoxic ischemic encephalopathy stage 3, then you may not want to offer ECMO. It is also not offered in conditions where there is uncontrollable bleeding or severe IVH, or if vessel sizes are too small for cannulation. This becomes kind of a relative contraindication. ECMO is also not traditionally offered for children with lethal chromosomal disorders such as trisomies of 13, 18, and 21, or any other lethal anomaly which is incompatible with survival. Now, where do we think of ECMO? It is when one or more of the following clinical criteria are met: when there is inadequate tissue oxygen delivery despite maximal therapy. So this can be indicated in the form of worsening organ dysfunction, severe metabolic acidosis, or rising lactate despite maximal cardiorespiratory support. For example, if you're on maximal doses of 4 inotropes and you have corrected intravascular volume, acidosis, blood glucose levels, calcium and electrolytes, etc., and you still are struggling to maintain adequate lactate and acid-base balance, or in a baby with severe hypoxic respiratory failure with an acute decompensation. So, a baby who is maximally supported with a mechanical ventilator, with, let's say, maximally acceptable MAP for the baby based on the gestational age. And if you still find that the PaO2 is less than 40 millimeters of mercury, or oxygenation index usually taken as more than 40 despite high frequency or nitric, or more than 40 with hemodynamic instability, is generally taken as an indication for ECMO. Severe pulmonary hypertension with evidence of right ventricular or left ventricular dysfunction, that is biventricular dysfunction, can also be an indication where you may consider it. But again, as we discussed, the contraindications would include irreversible organ dysfunction or organ damage, and babies who are very small, as of now, less than 34 weeks of postmenstrual age or less than 2000 grams weight, um, would become technically relative contraindications because of difficulties and challenges in cannulation and other challenges that, especially with anticoagulation, which can become a risk factor for bleeds in these babies. So overall, with these indications in mind, the common neonatal indications where ECMO is performed include meconium aspiration syndrome, CDH, PPHN, sepsis, and RDS. So as we discussed, ECMO for MAS, sepsis, and RDS has been progressively declining. Note that oxygenation index is calculated as a product of MAP into FiO2 divided by post-ductal PaO2. So MAP in centimeters of water into FiO2 percentage divided by PaO2 in millimeters of mercury. So if you are giving a baby MAP of mean airway pressure of 20 at FiO2 100 and the baby's PaO2 is 40, then your OI would be 20 into 100, which is 2000, divided by 40. So this will be 50. Also, failure to wean down FiO2 despite maximal therapy for 48 hours could be a place where you may want to think about it. So I'll now come to components of ECMO, having discussed the indications. So as we already discussed, we start with the blue line that indicates the drainage cannula, which is used for, of course, draining blood from the patient. This is then passed through, this is a bladder kind of structure where you have, pressure measurement that is available. And then the blood passes through a pump which pressurizes blood so that to facilitate its flow through the rest of the circuit, through the oxygenator and back to the lung. And then we have the oxygenator, which is also called as membrane lung. So you have at least 6 tubes flowing in and out of the oxygenator. One blood flow line in, one out. Then you have water in, water out. You have air in, that is oxygen rich air coming in from a blender, and CO2 rich gas that is vented out. Then post oxygenator, you have the red color line continuing. You can see blood passing through a heat exchanger to bring it back to room temperature. And then it passes through the return cannula back to the patient's body. Now, in this circuit, which has these 5 principal components, you also have 3 points wherein pressure is measured. So one pressure, that is P1 pressure, is prior to the pump, that is the lowest pressure in the ECMO circuit. Then post pump, pre-oxygenator, we have P2, which is the second pressure, which is the pre-membrane pressure. Post-membrane pressure is called as P3. I think these are coming up in the next figure. So as you can see here, we'll start from the drainage cannula. In this case, it is the femoral vein. So in general, in children more than 10 kgs, femoral vein is the preferred drainage cannula. But in newborns or in young infants, particularly when the weights are less than 10 kg, then jugular vein is usually the preferred drainage cannula. We'll again discuss this in cannulation in detail, but the dual lumen cannulae are not generally available also in our country. They are difficult to insert in newborn babies because the smallest size is around 13 French. And they are technically more difficult to insert, and the risk of recirculation might also be high with the dual lumen cannula. So generally, there is one separate cannula for drainage and one more for return line. So the drainage cannula here is in the femoral vein. So this passes through a ultrasonic bubble detector, which is a safety mechanism to remove any air bubbles in the circuit. Then we come to the venous pressure, which is also called as P1. So as we understand, venous pressure is usually 0 or negative pressure. So this pressure is generally negative. It refers to the negative suctioning pressure that is applied to extract blood via the drainage cannula. Now, having said that, P1 or pre-pump pressure can become more negative when there are some conditions like hypovolemia. So severe hypovolemia, blood loss, when there is a kink or obstruction in the drainage cannula, in the drainage catheter, P1 pressure can become more negative. And when this happens, we may find that, the ECMO flows are coming down. And if particularly when there is a leak in the pre-pump part of the circuit, air can get sucked into the circuit and this can become a problem. So it also can lead to a problem called as chattering, or the circuits kind of vigorously moving and creating some kind of a sound because of the inability to drain as much blood as required. So P1 is the first pressure that we measure, and this is the lowest pressure in the ECMO circuit, and generally a negative pressure of around minus 40 millimeters of mercury. Then the blood passes through the pump where the blood is kind of pressurized, and it is positive pressure is added on to the blood so that it can flow through the rest of the circuit. So P2, which is pre-membrane pressure just after the pump, is usually the highest pressure in the ECMO circuit, and this is positive pressure because it is post the pump. And this positive pressure is responsible for propelling blood through the oxygenator. Later we have P3, which is the post-membrane pressure, and P2 minus P3 is one of the important concepts to kind of monitor the integrity of the oxygenator or the membrane lung, called as transmembrane pressure gradient. So this delta P, that is P2 minus P3, which is also called as transmembrane pressure, is the pressure difference across the oxygenator. And although the absolute number may not really matter much, the trend of this transmembrane pressure difference can reflect the function of the oxygenator or the clot burden. So if we have excessive clot burden or resistance across the oxygenator, then transmembrane pressure or P2 minus P3 is going to become higher and higher. Post the oxygenator, of course, post membrane pressure is measured, and then the blood is pumped back. Usually it passes via one more bubble detector and then is pumped back into the return circuit into the in this case we are looking at VV ECMO, so it is going back into the venous, one of the tributaries of the SPC. In VA ECMO, this would generally be going back into an arterial axis, which can be either femoral artery or carotid artery. In newborns, as we discussed, central ECMO is also performed sometimes, where the cardiothoracic surgeon under direct vision may place the cannula into the patient's right atrium and the aorta. So what is the significance of measuring these pressures? Now, P1, as we discussed, is usually negative, but more negative P1 pressure can be seen with hypovolemia, kinked drainage lines, presence of leak somewhere in the proximal part of the ECMO circuit, blood loss. If the vein is collapsed completely, sometimes when the cannula is placed too deep or too superficial in the vein. For example, if the drainage line, which was supposed to be placed in the femoral vein, kind of went into somewhere into the intrahepatic portion of the IVC, hepatic vein. It could become so narrow that there could not be sufficient blood flow for the ECMO circuit, and hence it can become more negative. P2, as we discussed, is the highest pressure, highest positive pressure in the circuit, and it is pre-membrane. Generally, also P2 would be more than P3. But if you see both P2 and P3 concurrently increasing with the same kind of post transmembrane gradient, then this could represent resistance in the return cannula, either because of obstruction, kink, or a blood clot in the return cannula. And it can sometimes be also seen because of increased systemic vascular resistance, like very high dose of inotropes or vasoconstriction. So in these cases, when P2, P3 both are increasing and the blood flows are declining in the circuit, one may have to think of looking for any clot or obstruction in the return cannula, or trying to use some degree of systemic vasodilatation. On the other hand, if you only see P2 increasing progressively and P3 remaining the same or somewhat low, and P2 minus P3 increasing or widening of the transmembrane pressure differential, then this is a sign of a clot or resistance increasing within the oxygenator, and this will call for change in the oxygenator. Note that most of these parts of the circuit are available independently, and hence you can simply change the oxygenator instead of changing the whole circuit. Of course, changing the whole circuit is also an option, but that involves more cost. It also involves a lot of blood loss, because in adult ECMO, as much as 700, 800 ml of blood can simply be present only within the circuit, and this whole blood will then be lost when comparison to only changing the oxygenator. And then we'll have to freshly prime the new circuit completely. Now, if P2, P3 both increase, we discussed about cannula king, cannula obstruction, and increased systemic vascular resistance. So, based on the blood flows and based on these three pressures, one can understand where the problem lies, and this can help us significantly in troubleshooting during the ECMO run. Now, coming to cannulation, cannulation is it's available. Various cannulas are available, starting from the straight as well as the curved cannula that you can see on the left side. So these are some pictures of different cannula that are available commercially. On the right side, you can see the Medtronic Biomedicus arterial and venous cannula in the first two pictures. And you can also see the fifth picture of a dual lumen cannula, wherein a single cannula can be used for both drainage and for return. But of course, this comes with a significant practical challenge. It has to be a wider lumen venous vessel. So, because this is only the smallest size, if I understand right, is 13 French. And it also can be associated with significant recirculation. So the Origin and Covidin cannulas, I understand, are not available commercially in India. So what is the choice of the cannula size? So cannulation is usually done via neck cut down or by the percutaneous axis, less commonly. Ultrasound guided cannulation can also be done in bigger children. In newborns, it is usually done by a neck cut down by the cardiothoracic surgeon. And in post-op, post-cardiac surgery cases, ECMO can be done in the central route where directly as we discussed, the cannula can be placed in the right atrium and the aorta by the surgeon intraoperatively. So in VA ECMO, a single lumen venous and single lumen arterial cannula are preferred. Usually, the drainage cannula should be at least around 4 French bigger than the return cannula. So you may try to use 10 or 12 French venous cannula, single lumen, and 8 French arterial cannula, which is the smallest size ECMO cannula that is available. This is usually used for newborns. Veno-venous cannula, one may consider a dual lumen 13 French cannula as we discussed, but the vessel must be large enough to accommodate a larger cannula, which is required when we are considering a dual lumen venous cannula. So cannulation comes with its own challenges. I thank our PICU team for some of these slides, Dr. Parag, Dr. Kalyan, and Dr. Avinash. Cannulation challenges include the access where in babies less than 10 kgs, where we are discussing about newborns, it's not possible generally to go for percutaneous or ultrasound guided access. Usually one has to generally involve the cardiothoracic surgeon for a cut down, and we generally prefer to do a VA ECMO, and the preferred lines are right internal jugular vein and the right common carotid artery, and of course central VA ECMO is also done. So this is a picture taken from KIMS Secunderabad unit where central VA ECMO access has been placed intraoperatively. So this is about cannulation. The second important part is pump before we discuss about oxygenator and about the practical running of ECMO. Now the function of the pump in the ECMO circuit is of course to propel blood through the oxygenator and the rest of the circuit. And it must be able to do this to provide a wide range of flow. Usual range of flow would be around 80 to 120 ml per kg per minute without exerting shear stress on the red cells and causing excessive hemolysis. So there are two widely used types of pumps. The roller pump is actually less widely used. The centrifugal pump is the most commonly used type of pump. So if you look at the differences between the two, the roller pump is basically a positive displacement pump, which works by complete occlusion of the lumen and like positive displacement of the blood across the pump. As you can see, there is a circular motion of this kind of the central blade kind of thing, and that physically comes in contact with the outer surface of the pump, and it physically pushes the blood towards the oxygenator and towards back to the patient. So inflow in this is passive, and the outflow is completely a active positive displacement mechanism. The because it pushes the blood towards oxygenator, it is generally works at a constant flow. But the problem is whenever there is resistance, or when in a baby there is increased systemic vascular resistance because of some physiological fluctuations, or let's say there was some obstruction kink in the return cannula, this can even lead to rupture of tubings because it positively displaces blood at a constant pressure. On the other hand, the centrifugal pump that is more commonly used works on the principle of a controlled vortex. It generates a centrifugal force using a non-occlusive mechanism, wherein the flow is both preload and afterload sensitive. So, although there is a pump, the flow created by this vortex, like a kind of continuous kind of negative pressure by a Venturi mechanism, it is both dependent on the patient's preload as well as afterload. It is also afterload sensitive. So, it also depends upon the patient's blood volume status as well as the systemic vascular resistance. So, the disadvantage can be that flow can be quite variable and there can be sometimes cavitation. There was another type of pump called as the impeller pump, which is rarely used now because it causes excessive hemolysis. So these are the different companies that come with ECMO pumps with their names. One of the common companies that are used with no conflicts of interest from my end. Uh, we have the Mackey Rotaflow pump, which is again a centrifugal pump. These are the other companies that are displayed here for your reference. Now, oxygenator is the very vital part of the ECMO circuit. So this is also called as the membrane lung. Various types of circuits, various types of fibers have been used for preparing the oxygenator, including silicon, but this comes with the disadvantage of large surface area and high resistance. The PMP oxygenator is what is commonly used, which is made of polymethylpentene. It's gold standard for fiber for oxygenator. So these are all called hollow fiber oxygenators, and they can last many weeks to months. Polypropylene was the other fiber that was used for the genesis for making the oxygenator. Now, as we discussed earlier, the function of the oxygenator is periodically monitored by something called as the flashlight test. This is when you shine a torch across the oxygenator, usually we'll see a brilliant transillumination. And we also monitor by looking at the transmembrane pressure gradient, which is P2 minus P3. And when we look at post-membrane, post-oxygenated PaO2, the PaO2 should be at least 250 to 300 millimeters of mercury. So let me just see whether I can share this small video of an adult VV ECMO that was taken from our ICU, the medical ICU. So you can see this is the pump, and blood is flowing through. There's a flow sensor there. This is the oxygenator. And from the oxygenator, bright red oxygenated blood is now flowing back to the patient's written cannula, which is placed in the carotid, in the neck. So this was a morbidly obese adult patient with severe cardiorespiratory failure. This was the first neonatal eCPR that we had performed in our own unit, a newborn with meconium aspiration syndrome who had received, you can see, extensive CPR. So cardiothoracic surgeon had come for placing the venous and arterial line. That is the oxygenator in the blue color. So this typically with the Mackay circuit, the oxygenator is blue in color. The baby is also on multiple inotropes. Okay. So what are the settings in ECMO? Like we have settings on a ventilator, settings on CPAP. We need to understand that what we can usually influence or alter in the ECMO circuit include the flow. The flow, of course, depends on the preload and the afterload, and it is changed by changing the rotations or revolutions per minute in the ECMO pump. And usually, we target a flow of around 100 ml per kg per minute. It is slightly higher in VV ECMO. The other setting that we can control is the FiO2 of the blender of the oxygenator, and the sweep gas flow rate of the blender. So usually when we are dealing with hypoxemia, what we generally do I'm discussing here primarily when we are looking at VV ECMO, we will increase the ECMO flow, which improves the oxygenation. And we may also increase the FiO2 of the blender. The other things, the strategies that can be used would be to transfuse blood to improve hemoglobin and reduce oxygen demand by sedating the baby. When we are dealing with hypercapnia, on the other hand, the parameter that is to be changed would be the sweep gas flow rate, which is the gas flow of the sweep gas used across the blender, across the oxygenator. Initially, the gas flow rate is set equivalent to the blood flow rate. So, for example, if we are beginning ECMO for a 3 kilograms baby, and we started with the initial flow rate of, let's say, 300 ml per minute, we may also begin with a sweep gas flow rate of 0.3 liters per minute. And eventually, this can be changed up to 2:1 times of the ECMO flow. And we also need to optimize underlying issues like fever for overcoming CO2 retention. So this is again representing the management strategies for hypoxemia or hypercapnia. So in hypoxemia, um, it's pretty common as oxygenated blood always mixes with deoxygenated native circulation. However, SpO2 less than 85% may be critical, for which you may want to increase the flow. You may want to increase the FiO2 from the blender, but this may not have much return when the post-membrane, post-oxygenator SpO2 is already 100%. So further increase in FiO2 of the blender may not help in this situation. The other strategies would be to reduce native cardiac output by using a beta blocker, and last resorts would be to consider transfusion or adding another circuit in parallel. So you kind of add one more oxygenator in parallel, or we kind of maximally recruit the native lung using high ventilator settings. On the other hand, if we are dealing with hypercapnia, one generally will try to reduce or optimize fever, high body temperature, and CO2 buildup, and increase the sweep gas flow, similar to the minute ventilation on a mechanical ventilator. So practically, how do we start? One has to prepare and initiate ECMO first by setting up the team. Ideally, there should be 3 teams. One is the cannulation team, which would cannulate the baby either using a semi-Seldinger or Seldinger technique, or using a cut-down technique, which is open cannulation. Ultrasound-guided cannulation may be attempted in a bigger child. The second team will be like taking care of the circuit preparation, including priming of the circuit. Note that blood is used for priming in neonatal ECMO. And the third team is for optimizing the patient. So that team would be taking care of optimizing mechanical ventilator settings or inotropes while ECMO is being initiated. Note that the ECMO cannulae cannot be used for delivering inotropes, and one has to have separate venous lines for delivering inotropes at optimal doses. It is important here to choose the right mode of ECMO. So based on the underlying clinical indication, whether it is primarily pulmonary or cardiac, one would opt for the mode of ECMO. And then one has to also prime the circuit, keeping the oxygenator up, and choose the right dose of anticoagulation, targeting ACT levels at something around 140 to 160 seconds. Hand crank, importantly, is a safety mechanism whenever the pump fails, and this is to be placed below the level of the pump. So there must be adequate space of at least 200 to 250 SFT, with sufficient number of gas points and sufficient number of electricity points, because this baby would be a sick baby requiring multiple infusion pumps. At least usually 7 to 8 infusion pumps might be required. The baby also would be requiring a warmer, sometimes phototherapy units, or humidifier and mechanical ventilator circuit, connections, electricity connections. And so many connections would be required. And this is something that has to be well thought out of. The other requirements during ECMO include anticoagulation. Of course, there are multiple options for monitoring anticoagulation. The preferred drug, of course, is unfractionated heparin. In the blood that is used for priming, 100 units is usually added, and subsequently the maintenance dose is 20 to 30 units of unfractionated heparin per kg per hour. Heparin-induced thrombocytopenia is usually rare, and one tries to target an ACT of around 140 seconds. There are other alternatives, including the direct thrombin inhibitors like argatroban and bivaluridine, but these are all not usually used in neonatal ECMO. For monitoring anticoagulation, one generally uses the activated clotting time in seconds, which is the time taken for whole blood to clot in response to a fibrin activating agent. This can be affected a lot by the presence of the baby's coagulation factor levels, heparin, as well as platelet levels, as well as infection concerns. So, thromboelastography or TEG is one of the other useful modalities which measures the time for whole blood to form a clot and also measures clot lysis over 30 minutes and is useful for distinguishing between an underlying coagulopathy, surgical bleeding, or bleeding from heparin effect. The other important aspects during ECMO care include the need for blood products, wherein one would want to optimize hemoglobin levels of something around 11 to 12 grams per deciliter while the patient is on ECMO, bringing ventilator settings to rest parameters, not forgetting the principles of good VAP prevention and asepsis, lung toileting, and adequate ICU care, following all the bundles and checklists required for infection control and infection prevention, daily neurological assessment or a neurosonogram wherever it is feasible, and involvement of a multidisciplinary team for holistic management of the patient on ECMO. So rest ventilator settings usually in a newborn would be something like a PIP of 12 to 15 with a PEEP of 5 to 6 with a minimal FiO2 of 21 to 30% at low rate of 10 to 30 beats per minute with a I time of 0.5 seconds. Remember that the need for sedation can be very high because of the additional circulating blood within the ECMO circuit, which can consume a lot of sedation. The commonly used drugs include opioids, benzodiazepines, and sometimes dexmedetomidine. And one prefers generally to restrict fluid because the baby can have some pathological weight gain while being on ECMO, and this is generally restricted for fluid is generally restricted for preventing positive balance. And in cases where there is borderline renal dysfunction, one may also consider early CRRT. So when do we start thinking of weaning? We start thinking of weaning when on VV ECMO, the patient saturations are consistently more than 90% with adequate PaO2s on very minimal flows. Like let's say we have come to idle flows and the patient is still having good oxygenation, then that is a stage where one may want to give a trial of kind of stopping ECMO. And on the FiO2 of blender, once one reaches an FiO2 of below 50%, one can start reducing the sweep gas flow rates as well. On VA ECMO, which is what is normally performed in newborn babies, one starts considering weaning whenever the patient has adequate improvement in ejection fraction, which is more than 35%. You may use surrogates like velocity time integral on functional echocardiography, clinical parameters like MAP becoming normal, adequate urine output, normal blood pressures, lactates less than 2.5. And once you start seeing reverse flow from artery to vein in the ECMO circuit, that also is a sign of improving native cardiac function. This can be assessed by having a bridge in a VA ECMO as well. Common complications can be related to mechanical problems like failure of pump or oxygenator. So, in fact, failure of any of the components of ECMO, the most important components being oxygenator and pump failure. Sometimes heat exchanger can lead to hypothermia and DIC in the patient, and this needs to be promptly identified and rectified. Air or leak in the circuit, leak in the venous end of the circuit prior to the pump can lead to air getting sucked in, whereas a leak post the pump can lead to active bleeding and blood loss, and this may sometimes require even a blood transfusion. There can be accidental decannulation or displacement of the line, and especially when this is from the arterial cannula side, this can lead to catastrophic bleeding and needs urgent measures for stabilization of the child. Blocked cannula requiring a flush or replacement can also be a challenge. Some other patient-related problems may include hemorrhage, which can be from any site, hemoptysis, neurological problems, particularly IC bleed and infarcts common with young infants and children, infection concerns, vascular complications, particularly with VA ECMO, presence of left ventricular stunning with VA ECMO or RV stunning with the VV ECMO, hypertension, oliguria, and problems like pneumothorax or vessel injury during cannulation. So I'll just finish by discussing one brief case of troubleshooting case. This is this case is given to me by Dr. Kalyan from our PSU team. Thanks to him. So this is a 6-year-old child, 15 kgs, with history of a fever for 3 days and cough and fast breathing, and presented with low saturations. The child was intubated, ventilated for refractory hypoxemia, remained hemodynamically stable on only single inotrop. In view of hypoxemia, this child was initiated on VV-ECMO. So first of all, VV-ECMO was rightly initiated because this was a pure pulmonary problem. They have already given that the child was stable with only single inotrop. So this doesn't seem to be a very significant or refractory hemodynamic instability. So in terms of ECMO settings, the child was started on FiO2 100% with a flow of 1.5 liters per minute. So he's 15 kg, 100 ml per kg per minute. The sweep flow rate was also 1.5 liters per minute, which is 1:1 ratio of sweep gas flow to ECMO flow, with good color change across the oxygenator. So which shows that the oxygenator is functioning pretty well. So we can also look at PaO2 pre and post oxygenator. Generally, we expect 3 to 4 times increase in the PaO2, or post membrane PaO2 should be at least 250 to 300 millimeters of mercury. Immediately after starting ECMO, saturations improved. But after that, the saturation started declining to around 75%. They tried to increase the flow from 1.5 to 1.8 liters per minute, but this resulted in further decrease in saturations. So if you see this, then the problem is usually recirculation, or could be a faulty oxygen port. In this case, the child's drainage line and venous line, which were respectively the femoral and jugular veins were placed, were looking very close to each other. You can see that only 4 centimeter distance between the two. So after widening the distance between these two lines, the child's recirculation improved. So this is one case just to highlight that this is one of the common complications, particularly in VV ECMO. So this is another problem called as shattering that can happen when there is less preload, and this was rectified after the repositioning of the cannula was done. So I think I'll conclude by discussing about cost. So ECMO cost in general in a private setup would generally depend upon the circuit cost, which can be a one-time cost of anything between 1 to 2.5 lakhs. Most of the parts or components of the circuit are now available on rental basis as well. But the average cost of running of ECMO can be 3 lakhs at the time of initiation, significantly contributed by the cost of the circuit and the cannulae. And the working or running cost on a daily basis can be anything between 30 to 50,000 a day to as much as 80,000 to 1 lakh, based on the number of investigations and the other antibiotics and disposables that the child is requiring. So choosing the right patient or choosing the right time for initiating ECMO can be crucial. Reducing cost is an important consideration while performing ECMO in setups such as ours, wherein one needs to think of some strategies like, trying to be associated with an adult ECMO program. Establishing ECMO in public sector hospitals can significantly bring down the cost for patients in need. But of course, this requires a lot of close knitted team coordination. Bringing it under government health schemes like Ayushman Bharat and Arogyashri could be the way forward. And of course, motivating patients to go for health insurance is something that can be time saving. So ECMO outcomes in newborn can vary between 87% in pulmonary cases, which is survival till decannulation. And in cardiac ECMO, the survival can be slightly lower. There are multiple useful resources from the ELSO website, which are all readily available. You have updated guidelines for neonatal respiratory failure, which are, I think, updated as of 2022. So for initiating ECMO in any of your setups, it is important to have the right team, which would include the cardiothoracic surgeon, cardiologist, perfusionist, and an ECMO physician, having an in-house blood bank and 24/7 lab availability, choosing the right patient and initiating at the right time, having team networking, team training, and regular high-fidelity simulation-based training could be important tools for taking this forward in your own setups. But one has to remember that ECMO is only like a bridge to survival, and one should never start venturing into the bridge when the final destination is not clear. Thank you for joining us, and we'll hope to see you all again in the next session next Friday.